Hi, my name is Dr. Justin Kuhlman, and I'm a second year internal medicine resident at the Mayo Clinic here in Jacksonville, Florida. I'm going to present this clinical vignette on behalf of myself, Dr. Mustafa, Dr. Zhang, and Dr. Tun. We herein present an interesting case of lymphoma in a patient with a history of heart failure and other cardiac conditions. To provide you with a brief background, effusion-based lymphoma is a specific subtype of non-Hodgkin lymphoma, which manifests as a serous effusion within a body cavity, typically in the pleural space, but also in the peritoneal cavity and other places as well. It's most commonly found in association with Kaposi sarcoma, also known as HHV8 infection, but when it is not, it's often found in association with HIV, hepatitis C, hepatitis B, Epstein-Barr virus infection, organ transplant patients, or in rare cases, fluid overload states. We're going to present an interesting and rare case of effusion-based lymphoma which developed in the setting of heart failure and other cardiac conditions. Our case begins with an 81-year-old male with a past medical history that's pretty extensive, consisting of coronary artery disease, valvular heart disease status post-mitral valve replacement, and tricuspid annuloplasty ring implant, a CABG performed years prior, persistent atrial fibrillation, hypertension, heart failure with preserved ejection fraction, and previous right-sided pleural effusions, who presented to his cardiologist's office complaining of increased fatigue, cough, orthopnea, and exertional dyspnea over the previous 3 to 4 weeks. A chest x-ray was performed, and as demonstrated in Figure 1, demonstrated a large right-sided pleural effusion. Cytology results, as well as immunohistochemistry staining, as appreciated in Figure 2, revealed large atypical lymphocytes on cytological examination, seen in Figure 2a. This was already concerning for lymphoma. Immunohistochemistry staining, seen in Figure 2b through h, also supported a diagnosis of lymphoma, as B-cell markers were positive for PAX5, CD5, BCL2, BCL6, MUM1, and an elevated proliferative rate of 90% on Ki67 staining. It is important to note that testing for viral etiologies, such as Epstein-Barr virus infection, HHV8, hepatitis B, hepatitis C, and HIV were all negative. This supported a diagnosis of lymphoma, effusion-based lymphoma particularly, without another source of primary malignancy, which was confirmed on PET scan demonstrated in Figure 3. There are no abnormal FDG uptake anywhere else throughout the body. Therefore, the effusion was deemed to be the primary source of malignancy, and the diagnosis was consistent with effusion-based diffuse large B-cell lymphoma. The patient then underwent 6 cycles of anthracycline-based chemotherapy consisting of the R-CHOP regimen. This is composed of rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. Following completion of treatment, the patient underwent repeat scans, which was negative for recurrence and demonstrated complete remission. Since then, the patient has undergone surveillance imaging every 4 to 6 months without any signs of recurrence. He currently remains in complete remission 5.5 years following the time of his original diagnosis, which is an amazing outcome. As previously stated, effusion-based lymphoma is typically associated with HHV8, but when it is not, is typically found in association with other viral etiologies or an immunocompromised host. The current case, however, excluded viral etiologies, and ultimately the effusion-based lymphoma was only discovered in association with heart failure and repeated pleural effusions in this setting. Cytological and immunohistochemistry staining, combined with the high index of suspicion, was critical in order to arrive at a proper diagnosis of effusion-based lymphoma. It seems that fluid overload states may be directly involved in the pathogenesis of effusion-based lymphoma, as nearly 50% of cases that are without HHV8 infection have been discovered in fluid overload states, such as liver cirrhosis, heart failure, and other etiologies as well. It's possible that repeated serosal stimulation in the setting of recurrent effusions stimulates cytokines and other forms of pathogenesis stimulating the lymphoma. HHV8 negative effusion-based lymphoma seems to respond extremely well to thoracentesis and the standard anthracycline-based chemoimmunotherapy consisting of R-CHOP, as demonstrated in the current case. Further investigation into the etiology of effusion-based lymphoma is warranted in order to further characterize and understand this rare entity, which seems to be associated with fluid overload states, and in the current case, interestingly, with heart failure and other cardiac history. Thank you for listening to our fascinating tale of how heart failure may be a possible cause of lymphoma.